Welcome to The Focused View, the podcast for eye care professionals across Australia. In each episode, we bring together leaders from optometry, optical dispensing, and business to share insights, practical strategies, and the latest developments shaping independent practice today. I'm your host, Michael Nasser, and together we'll explore how innovation, collaboration, and smart business thinking can drive growth, enhance patient care, and strengthen the future of independent optometry. Whether you're a student, an early career professional, or an established practice owner, The Focused View is your go-to source for knowledge, inspiration, and connection. The Focused View is brought to you by Vision Connection, supporting independent eye care professionals across Australia through collaboration, education, and business growth. By working closely with leading suppliers and industry partners, Vision Connection offers unique opportunities that help independents stand out and succeed. To find out more, visit their website, visionconnection.com.au.
I built Dry Eye Impact because there's such a huge need out there for optometrists to treat dry eye and treat it well so patients get good outcomes. And we have so many new technologies and solutions to help people, yet we're still kind of not maybe in that phase within like confidence in practice, or not sure how to bring that advanced technology into practice. But there's just such an opportunity for us to do better in the dry eye space.
Welcome to The Focused View, the podcast for eye care professionals across Australia. In each episode, we bring together leaders from optometry, optical dispensing, and business to share insights, practical strategies, and the latest developments shaping independent practice today. I'm your host, Michael Nasser, and together we'll explore how innovation, collaboration, and smart business thinking can drive growth, enhance patient care, and strengthen the future of independent optometry. Whether you're a student, an early career professional, or an established practice owner, The Focused View is your go-to source for knowledge, inspiration, and connection. The Focused View is brought to you by Vision Connection, supporting independent eye care professionals across Australia through collaboration, education, and business growth. By working closely with leading suppliers and industry partners, Vision Connection offers unique opportunities that help independents stand out and succeed. To find out more, visit their website, visionconnection.com.au. In today's episode, we're taking a closer look at dry eye and why it deserves a place in every optometry practice, regardless of how much technology, time, or resources you currently have. Shaina Zheng is back, and this time we're getting very practical. We'll talk about how to identify dry eye within a standard consultation, where to start if you have limited equipment, when to consider more advanced technology, and how to build confidence and experience to manage these patients effectively. We'll also explore what it takes to get the whole practice behind the service, from team culture and patient communication to referrals and avoiding some of the common mistakes practices make when introducing dry eye into their service. So if you've been thinking about bringing dry eye into your practice, or you're looking to take what you already offer to the next level, this conversation's for you. Let's get into it. Shaina, welcome back to the show. It's great to have you on.
Thanks, Michael. It's really great to be here chatting with you today.
Yeah, looking forward to it. Just for those that aren't familiar with who you are, can you just give us a quick recap as to, who you are and what you're about and, everything that you're doing in optometry?
So my name is Shaina Zheng. I'm a clinical optometrist at Eye Care Plus Mermaid Beach, where my husband and I co-own the practice, and we have a special focus on dry eye treatment and management. I've created an organization called Dry Eye Impact to help bring dry eye to other practices and really improve the level of dry eye care within our industry.
And I'm really looking forward to today's episode because we are going to really deep dive. I guess one of these newer areas of optometry that have developed in the last couple of years, a lot of the people have referred to these as niches, and dry eye is definitely one of those categories and areas that seems to be evolving. and evolving quite rapidly. So getting that out to the audience, I think, is an important message. So thanks for doing that. But as we get going on this, you've spoken openly about having experiences with dry eye disease yourself. How did that shape the way you see it, and I guess how you're incorporating it into the way you practice?
So I was diagnosed as a child, and to be honest, I didn't really understand what it meant then. I didn't really understand what it meant in uni, and I still didn't understand what it meant after graduating and being an optometrist and practicing for a number of years. It probably took me at least 5 years of practice as an optometrist before I started to understand the condition a bit better, and started looking at it not just as a symptom, because a lot of the time patients would come in with the symptoms and I would just be like, well, let's try to manage that, treat that. And I didn't realize it was a chronic condition that required proactive management so patients can get better outcomes. And now that I realize that, I'm a big advocate for education and explaining the condition to the patients and the underlying drivers behind the dry eye, as opposed to just the discomfort that they're feeling, really making them understand that it's not just a discomfort, but it's an actual disease.
Mm. And I guess having that experience and having it firsthand and living it yourself and understanding the complexity it took for you to reach that point, how does it change the way that you talk to patients, and the frustration that you can imagine that they would have if they're experiencing, things like this?
So one of the things I think it's really helped me listen to patients. I think dry eye patients really need to be listened to because they've been struggling with uncomfortable eyes for so long that they're wanting someone to listen and really listen. Some of the stories that they share with me echo some of the stories that I have. So for instance, I have troubles driving at night. My eyes will burn, they'll sting and they'll water, and I don't see very well when my eyes are watering. And it's a story that I hear from many of my patients who have dry eyes. This is something that affects them. Something so simple like driving home from work can be so difficult for someone who does have dry eyes. So these little things, the stories that they tell, if we listen to them, we'll understand the impact it has on them. It's not just dry eye to them, it impacts on what they do day to day. And being a dry eye sufferer, I suppose it's easier to relate to what they're going through because I do genuinely understand how it's impacting them, because it does impact me to some extent. Maybe not the same severity, but everyone is different.
And having that connection, obviously, we've spoken to it a few times already, but it obviously inspires you to drive yourself in this area, in this, I guess, niche. But have you always been as passionate as you are now about it, or is it something that you developed over a period of time, practicing, and then I guess honing in your skills with regards to how you manage it now? I guess from a clinical point of view, was that an evolution, or was it something that you had from the outset going into this?
So I don't think I had it straight away. Like I said, I didn't really understand the condition until quite a bit after clinical practice. But once I understood it, and I was better able to manage the issues, like for instance, if someone had dry eye because of blepharitis and we treated their blepharitis and their eyes felt better, that kind of gave me confidence and also kind of fueled, I guess, the desire to help these patients. Because when you're able to address something that no one's been able to help them with and they feel better, it's quite satisfying to be able to help people in that way. I think, when we first started, we had really basic stuff, hot compresses, some foam to wash the eyes for blepharitis, hot compress for meibomian gland dysfunction, blephastine. And I wasn't getting a lot of people coming back to tell me that the eyes were feeling like amazing, but I did have a few patients who would say, oh, look, no one's told me about this, but these hot compresses, they're really helping my eyes, and then that feels nice. But it wasn't really until we invested into the advanced dry eye technologies that I start to really get excited about dry eye, because I was able to make measurable changes for the patients. And once you can, make that change and make someone go from uncomfortable and unhappy to happy and not having to think about their eyes, that kind of fuels the passion because you're helping these people who, really need to be helped.
Mm. And I guess as time has progressed, and obviously, something that even in my opening, framing it as specialty, and I know this is something that you're quite passionate about too, there is this perception that it is a specialty and, something that requires a dedicated clinic or expensive equipment. I mean, you did touch on advanced dry eye technologies then, and I guess at some point I want to unpack what that, looks like. But when it comes to that framing of it being something that is highly specialized or very specialized, and you need to do this, and that, and it includes expensive equipment and deep clinical training, what's your response to that? And I guess, how do you see that progressing going forward?
So I don't think dry eye should be seen as a niche, although there will be some practitioners who've had more experience and who've, dealt with a lot more cases and are a lot more confident in how they treat the patients that come to see them with dry eye. But the technology is evolving rapidly. Many optometrists will have access to some type of dry eye treatment within their scope. We already have access to eye drops, access to prescription eye drops like cyclosporin, steroids. There's talk about more eye drops coming out to market that address kind of these inflammatory issues. And then there are simple things like in-office eyelid cleaning. So there are consumables that you can buy and clean the lids within practice that don't cost a lot, and little consumables that are available that fit into the practice quite easily. And then, of course, there are the advanced technologies, but I probably wouldn't be starting there until you got a bit more into the basics of, getting some success with some of the treatments that are already available to you.
And I guess from your point of view, how would you approach somebody that's thinking about it just from the initial, I guess, phase with regards to, all right, this is something that it is specialized. Obviously, there is a different way of potentially approaching this new. Again, I use specialty a lot because even myself, I've been, influenced to think that. But if you're in that sort of practice setting and you want to incorporate something and you're thinking about this as something that you want to, progress on, what would be the mentality you would suggest someone start off with so that they're not doing themselves or their business a disadvantage as well at the same time?
I guess we have to remember that dry eye is a chronic condition. So if it's not managed well in the mild stages, it can go on to become moderate and severe, which moderate and severe cases tend better with the advanced technology. But if we're managing it at the mild stages, simple things like hot compresses, eyelid hygiene, nutrition, supplementation, that's enough to make a change for a lot of the mild cases, as well as environmental factors and recommendations about what they can do as daily habits to improve their dry eyes. I think the biggest thing that practitioners can do better is take more time in explaining the dry eye diagnosis to the patient and then just educating them on why they have dry eye and the underlying drivers. Just getting into the practice of learning the communication is really important so you understand the disease, understand how to communicate it. But then down the track, if you do invest in advanced technology, you're able to communicate how that technology addresses what you've explained to them already. It just fits in really nicely. So once you understand how to explain it to the patient, you can then bring the technology and explain how this technology is positioned as a solution to get them to the next point if they've tried all the other things and they haven't kind of got that change that they need.
And I think that, that sort of speaks to the professional wanting to do it. And it's almost like, this is who we're speaking to. It's like you've identified that this is something that, you're resonating with and this is something that you want to progress. And so that mentality point of view is already sort of like, we've got the tick there. And so we're kind of now phasing into, okay, well, this is something of interest and we do want to progress this. What then would you see to be the biggest barrier or the next barrier with regards to getting involved? Is it more the clinical understanding? Is it more the educational piece and upskilling yourself in that Is it the mentality still, or could it be maybe your surroundings and the practice environment that you're in? What are some of those big barriers that you see at the early stages that might, I guess, detract or deter somebody from then progressing, and an optom specifically, obviously, in this case?
I definitely think there are barriers in the sense of time. I think probably time is one of the biggest barriers. Dry eye management requires quite a bit of time. And if you're already working in a busy practice, you might be short on time. So I acknowledge that that's a big barrier. Some appointments can take up to an hour, dependent on the type of patient that comes in. If you're not working in a very busy practice and you have the time, then I don't think the barrier is a clinical barrier. I think as optometrists, we do go through extensive therapeutic training. We can detect, diagnose dry eye, and we know quite a lot of the treatment options out there. Probably the barrier there is the confidence to bring something new in. Yeah, I think, confidence to start and to push through the uncertainty and the discomfort of managing dry eye. Because managing dry eye, I kind of explained to other optometrists, it's not as simple as a refraction. Most of the time, someone comes in, we do a refraction, we get them seeing 6/6, and they walk out there and they've got a pair of glasses that get them seeing well. With dry eye, it's a multifactorial disease. So you might see many drivers of their dry eye, and you might treat one or treat all of them, and they may not respond in the way that you expect. So it's not as clean cut as you do this treatment, they come back and they're better. There's a lot of, not trial and error, but a lot of adjustment required dependent on the patient. And that learning curve, I think that's a barrier, because when you go through that learning curve, it will be uncomfortable, very uncomfortable. But the more you do it, the better you get, the better you are at kind of detecting the patterns and knowing which treatment might work better for this type of case. So it's just getting past that initial barrier of learning.
And correct me if I'm wrong here, but I sort of put that in the category of experience and not being experienced in doing it. And then obviously the more you do it, you get more experience, you know what to look for. And again, this is maybe somewhere you need to correct me, is with regards to the way that this type of experience would be gained is in the practice. And if your practice doesn't do that naturally, or it's not part of the ecosystem there, it's like, well, you need to facilitate and create that ecosystem. And that's going to be the next phase of what we speak about. But I would imagine that there is a lot of support mechanisms in and around the industry if it's not something that in your practice currently is doing. But obviously, like you said, it could be an hour consultation. So if it's going to be something you're going to implement, you would need to ensure that from a planning point of view, you're allocating some times of the week where you can fit people in to do a consultation like this and have the time that you need. And so part of that comes down to the strategy with regards to A, wanting to do it, and then B, how do we map this out? And as part of that, how am I getting that confidence in the interim at the beginning phases as I start to build up in this area? And that's obviously where the likes of some of the initiatives we'll speak about later are, but a bit networking, I guess, from that point of view as well. I guess from that category, how would you speak to that in terms of somebody that's in that environment and they don't have that support mechanism in the practice environment? They've got to reach out. What would you say to someone like that?
It's really exciting to be in dry eye now. I'd say when I first got into IPL and dry eye advanced technologies, it wasn't so exciting because I got a lot of pushback from the industry or from my peers or from other optometrists who didn't necessarily believe in the evidence or believe in the research. But now things are different. There's so much research out there, extensive research through global eye care professionals, and they've come up together to create JUICE-3, which is clinical protocols, best practice for dry eye management up to date. And now we have things like the Dry Eye Society, which is an organization that, brings optometrists who are interested in treating dry eye together. So I'd say now there's so many people out there that you can kind of connect to, reach out to, like-minded practitioners who believe in the technology, have seen how the technology works and how it actually helps patients in real life, which wasn't there, I'd say, 5 years ago, but now It's here. And if you wanted to reach out to someone, you probably know someone already who's using or doing dry eyes at that level that you could just reach out to and chat with and kind of not feel pushback. Whereas, like I said, back in the day, there was quite a lot of pushback, and I feel and I sense that changing. People are a lot more optimistic towards dry eye and going down that way as a professional practice in optometry.
Yeah, I absolutely feel that as well. And I guess the next phase is getting practical and how this now comes to play. I think when I sort of put forward, these next few concepts or thoughts, it'd be interesting to get your take on it, obviously from the optometrist point of view, because that's where the clinical aspect of this is. But also, I think we speak to a lot of obviously practice managers and practice owners, and they might be dispensers or they might not necessarily be, they just might be business owners. And I would imagine that you've got to have buy-in at every level, including staff too. And so from that point of view, when we get practical, we'll speak about the specifics for the optometrist. But if you can also give us some parameters with regards to perhaps considerations a store owner might need to give or an optical dispenser might need to think about as well, because obviously it is that sort of total experience. So if a practitioner, has no dry eye specific equipment at all today, and they're listening to this podcast and they're going, you know what, I'm going to start down this path. What can they do in a standard consultation to start to identify and addressing dry eye?
So it only really takes 3 minutes within a standard consult to do a dry eye check. And so it can fit into your routine practice quite easily. The first thing to do is, within history, ask if they've got red, sore, irritated, itchy, watery, or tired eyes. Probably takes 1 minute. They'll either say yes or no. If they say yes, it's already symptomatic. So write that in history. The next thing you do when you're on the slit lamp is put in a bit of fluorescein dye, do your normal consult, and then check for any corneal staining, check tear breakup time. That'll take you maybe 1 or 2 minutes. And then the third thing that I recommend that you do is just look at the eyelids and the eyelashes, which you would do anyway when you're looking at the slit lamp, and just assess if there's any blepharitis, if there's any meibomian gland capping. Really, that shouldn't take you any extra time. Once you see those 3 things and you add them to your initial consult consistently, you'll be able to pick up dry eyes quite easily, because if they're symptomatic, all you need is one of those signs: reduced tear breakup time, some staining, or if you're seeing blepharitis or meibomian gland dysfunction, and you can diagnose it on the spot without any fancy equipment. I'd still recommend, though, if you do diagnose it at that appointment, to tell the patient, then get them back in for a more proper dry eye assessment where you can talk about the condition a bit more, really spend the time to communicate what's going on. And at that appointment, you can always do your diagnostics if you have the equipment and you want to, do a more comprehensive check. That's the time to do it then. Within the initial consult or within your standard consult, you just need to identify it and communicate that to the patient.
And this is probably going to then go into another area, and it's more of a legal area. And I think sometimes there are instances like this where you almost, as a clinical professional, want to ensure that you're giving the best possible advice at any instance. So in doing something like this, you're also ticking off, I guess, a duty of care component with regards to ensuring that you're addressing these items if you've seen them. So it actually, if anything, makes your consultation a lot more robust, and obviously, it can evolve and be a lot more holistic in its nature. Now, I'm not an optometrist, so a lot of the technicalities within the consultation room will go straight over my head. But I guess for the optometrists that are listening and they're going down this path of, starting to factor this in, are there key parameters or observations that, optoms should be setting or looking at as a baseline? Is there something that they should be considering in all of this? Or is it just a matter of observing, what they would normally observe? And if they see the difference, is it something that they would manage? I mean, because consistency is a word you've used quite a lot. And so at what point does that become an area of, okay, well, I've figured something out and we're then now transitioning into some type of remedy or some type of, management program in and around that?
So if you've detected dry eye, you've diagnosed dry eye with the patient, like I said, you need to take the time to explain what's going on, and you need to understand and communicate the driver behind the reason why they have the dry eye. And then you just need to address them. So, for instance, they might have blepharitis on their lashes. So you just need to give them a solution in regards to treating that blepharitis. And there are many different treatments. You could use a foam to wash the eye, and then it advances into in-office treatments where you do lid debridement, lid cleaning, and even potentially going into more advanced treatments for blepharitis. But there's a spectrum, and you could just use what you have within practice. And if you don't have anything, I guess you can recommend them to go to the pharmacist to buy some eye wash or eye blepharitis wash. But I'd recommend that you have that in your practice to at least hand to the patient so they can address it. In terms of, I guess, key parameters, you can diagnose dry eye if you see a reduced tear breakup time on fluorescein stain for less than 5 seconds. So you can diagnose it, just like that. The patient does have to be symptomatic though. So you've got to make sure that you're asking the questions in history, because if they've got a reduced tear breakup time, but they're not symptomatic, you do have to kind of ask the questions and tease them out, because sometimes patients don't tell you. I had a patient where she didn't have really any obvious signs, but I just kind of squeezed on her eyelids and she had a few little kind of caps and the glands looked a bit blocked. So I just asked her, like, do your eyes like water? Do they, not thinking that she would say yes because she's never said anything before. And then she's like, yeah, all the time. They water all the time. And then she like went on this whole spiel of how it annoyed her. And I didn't get this out of her in history. But then like she was saying all of that. And then I asked her like, well, how come you didn't ever tell me about this? And she said that her mum's had it.
Oh, wow.
Before. So she just thought she had inherited it from her mum, and it was just something that she had to live with because her mum was told that there was nothing that could be done about it. And I was like, oh, wow, I'm so glad I pressed on those just to see potentially and then ask the questions. So sometimes, that she was lucky, I did that. Sometimes I don't always do that, but I thought, oh, maybe that's something I should consider in the future, just like a little, just to check the glands, because it doesn't take very long. But I haven't added it specifically to my protocol. But imagine if I did, how many more we could potentially kind of tease out that don't have the real obvious signs.
And you've mentioned there the conversation and the way that you're asking questions and conversing with the patient in that instance. And obviously there are some actions there that are, then prompting further questioning. And in that instance, that seems to be almost life-changing for that lady because, she's gone with this perception, oh man, I'm not sure if it was, but yeah, it's questioning and it's like, oh, well, hold on, this is not how it should be. And there's maybe some remedy in and around this. So if it comes to questioning and the way that you're engaging with the patient with, dry eye, obviously, at the front of mind, how would you change your dialogue, or what sort of questions would you want to factor in over and above what you would normally ask? And do you make, you mentioned protocol, do you make that standard in all your consultations, or do you just figure out what to do at any given time?
I think it should be a standard question that you ask. I don't necessarily think that you have to ask patients, do your eyes feel dry? A lot of the time they don't know what that means. They don't know what that means. But it can take a second. You just have to ask, you have sore eyes, red eyes, itchy eyes, watery eyes, gritty eyes, burning eyes, stinging eyes, or gunky eyes. That pretty much covers everything. So if you ask that and they say no, then you're probably like, even if they do have signs, they don't have the symptoms. So maybe just something I mentioned, but not something I have to really go really deep into. But if they say yes to any of those things, you should already be thinking, I might be seeing something on the slit lamp. I might be potentially seeing something. In saying that, sometimes you don't see anything on the slit lamp. And that's because that's all you've got, a slit lamp and your fluorescein stain. Sometimes you need more or different devices. In dry eye, there's this term pain without stain, which means that the patient feels uncomfortable. They complain of dry eye symptoms or they complain of eye discomfort, But when we look on the slit lamp, we don't see, reduced tear breakup time, or we don't see any corneal staining, and it's invisible. You look at the eye and it looks normal. In those cases, there are probably other diagnostic tests that are necessary that you'd have to invest into if you don't have it. You might say you don't have dry eye, but that might not be the case. They might actually have it. We just don't have the tools to diagnose it with just the slit lamp. So some of the tools would be tear osmolarity. Sometimes you do that test and you'll realize, oh, yeah, their tears are, not what they should be. And this is actually a diagnosis of dry eye. And sometimes it could be their corneal sensitivity. So if you don't have a way of measuring these, you might miss the cases, and you might unfortunately say that they don't have dry eye when they might still actually have some other signs there. There are other things like mammography, where you can look at the meibomian glands. You need a specialized device for that. And then there's more research now to show that a lot of the signs that we see on the slit lamp are already signs that there's inflammation or there's cell damage. And there are technologies now where you can image the cornea at 800 times magnification and actually see the cells and the inflammatory cells that are causing those symptoms that patients are feeling, even though you can't see it on a slit lamp. We don't have that available for practitioners. That's purely, a lot of that technology is used by researchers. But it's interesting. Imagine one day if we had those devices in our practices to pick up those cases where they feel the pain or the discomfort, but we can't see anything under the slit lamp.
Yeah. Sounds like there's more progression in that space happening. And that segues, I guess, well into the next section. And that is, as we start to build, going from basic, and we've spoken about some of the basic things that you can do in the consultation and with, things that are readily available in most practices, to more of that advanced type of, I guess, analysis and diagnosis, and then obviously onto treatment. If I was to think about it at a level, level 1, level 2, level 3, and you've already identified some probably level 2 items there potentially, how does it go the next level? Like, at what point do you start going, and what would that next piece of equipment or that next, solution, or what does that look like as you start to evolve, from a more basic, I guess, solution in this regard?
Yeah, so level 1 would be eye drops, lubricating eye drops, oil-based eye drops, hot compresses, foams, eyelid hygiene, all the basic stuff that we've all learned before, we all know about. And they do work, but for those milder cases. And then the next level up, which is still available to a lot of optoms, is to prescribe prescription eye drops like cyclosporin, steroid eye drops, and things like blephasteam, so in-office heating and expression, so meibomian gland expression, if the patient has meibomian gland dysfunction, and even, as we discussed, the in-office eye cleans if blepharitis is present. So those things can be done relatively inexpensively, and they're options, good options for patients. And then you probably go to like more the moderate and advanced severe cases where you might have tried level 1 stuff, didn't work, so you moved on to level 2 plus level 1 stuff, and they're still not getting the response after combining, adjunctive therapies. Because I talk about level 1, level 2, level 3, but really they can all be adjunctive. So you could be doing level 1, 2, 3 all together as well. Like for some of the severe cases, it's
a combination of.
Yeah, correct. So I call it adjunct therapy. I think we're past the point now where we're talking about what treatment is better for dry eye, which device is better for dry eye. I think we've moved beyond that point, and we've realized that they all have a place in the toolkit as long as you use the right one for the presenting case, and they can be used together if needed. So like, just because you're treating someone with an advanced device doesn't mean that they can't still be doing lubricating eye drops and hot compresses at the same time. Like, they work together, actually. They work better synergistically, because doing things at home as a habit is also just as important as, actively treating within the practice. They both have a role. But if you go into level 3 or more moderate to severe cases, in those chronic dry eye conditions where you see a lot of eyelid telangiectasia or extensive corneal staining, or if they have a history of recurrent styes, you would be looking at more of the advanced treatments like IPL, radiofrequency, low-level light therapy, Rexon eye treatment. They have that place at that next level. But I always tell patients it's still good for them to be doing things at the level 1 and level 2 to kind of aid in what we're doing, because it is a chronic condition. So even if we do treat with IPL and things feel good and they don't do anything, the more they maintain their habits or their good habits for their condition, the better it will be for them in the long term.
Okay. And so for a practice owner who's convinced about the idea and it's all sounding good and they sort of want to go from this basic to advanced stage, where should they start and what should be some of the first pieces of equipment or, the first processes that they should start to do with regards to now elevating the game to going from basic to more advanced?
I think it's really important to invest in a camera or like diagnostics or a slit lamp camera if you don't already have that. There is no better way to communicate a diagnosis of dry eye than being able to present it to the patient visually. It makes the explanation much easier. It makes the patient understand what's going on, and they're much more committed and engaged to move on to the next step. In terms of devices and technology, there are so many devices out there now. We've got about 4 or 5 of them. So we have had a taste of, I guess, what's on the market. And I do think they are all good devices. It would depend really on your patient demographic, who you see, what type of dry eye you see more, what fits into your workflow, because each device has its pros and cons. So, I'd love to give like a blanket, you should get this device, but really you got to look at your own practice. You've got to see, how many appointments you have available. Do you have a lot of time? Do you have a lot of front end staff? Do you have a lot of optometry cover? Yeah. That would kind of guide you to the device that would be most suitable for your practice.
That makes sense because, and I guess as you start to, go down the path and get runs on the board, it'll become obvious what the next piece of equipment or the next process that you would need to incorporate in relatively quickly, because that need will just naturally start to occur once you start looking for it. You've built a really sophisticated dry offering up in Mermaid Beach, where you're at, including being one of the first in Australia to offer IPL and radiofrequency treatment, correct me if I'm wrong there. How much of what you do now relies on the technology and how much is on the foundational processes?
So we were the first practice in Australia to offer the Envision, which is the IPL and radiofrequency device.
Yeah.
I would say we rely on both. So I'm a firm believer in patients having good eye habits. I use the analogy that dentists get us to brush our teeth every day. That helps prevent cavities, because if we get cavities, our teeth will be in pain. And we should really have these habits for our eyes as well, because if we do these habits, they will actually help us from developing a more severe case of dry eye, which if we don't manage leads to eye pain. Right. So I really think they're kind of pretty synergistic, and a lot of people don't realize that they need to be taking care of their eyes at home, and it's a good habit to have. And it's all about that foundational education initially, and then moving on to the next steps. So we do see a lot of moderate to severe dry eye at our practice. So we do use the IPL and the radio frequency quite a bit. But then we do have patients with more milder or moderate cases. But regardless, we still get them to do the basics. I call those eye habits, I tell the patients, it's your homework, dry eye homework, and I usually write their name. So, if you were my patient, I'd write Michael's homework on the sheet of paper, which just outlines a few simple things that they can do that are relevant to them on an ongoing basis, similar to the dentist telling them to brush their teeth.
And I guess if you're looking at dry eye as well, over and above the clinical side, obviously the technology side, there is obviously, I would assume, a need to have the whole practice buy into this for it to be successfully rolled out. And we did sort of touch on this earlier, but it doesn't obviously happen in isolation. So, how have you and how have you seen other practices roll this into their offerings, their services, from front of house to dispensers and the support staff? I mean, how does that work? And is it something that you actively train on and educate with them as well, or is it something that you just leave pretty much to the optometrists and the clinical professionals, I guess, in the practice?
So you have to involve everyone in the practice. Everyone is involved. I'm a real firm believer that every team member must go through the dry eye patient journey. So what I mean by that is they need to have a dry eye assessment. They need to go through the process. And if they're diagnosed with dry eye at the appointment, would walk them through their treatment options, and we would put them through the treatment process. Everyone that works in our practice, interestingly enough, has dry eye.
Right.
Crazy, but a lot of people do. So they've all gone through the process. And once you've gone through the process, you kind of know what to expect. You've got your lived experience to share with the other patients who come to see us at our practice. And then we go through the follow-ups with them, the reviews. And as dry eye is a chronic condition, our team members, they still require reviews, appointments, treatments over time if things drop off. So they all understand that dry eye is really like a process and a journey. And it's not just they come in, they get their treatment and they're cured. And it really is a lot more to dry eyes, as it is a chronic condition, something that someone will live with forever. But we need to manage it to the point where they're comfortable with where they're at.
Yeah, I mean, it's dry eye management, and so it's the management of it, I guess, and that means that it's not just a once-off thing. So that makes total sense. You've spoken about a culture-first approach through dry eye impact specifically. What does that mean for you in practice? And I mean, how is it different from just implementing a protocol or a process? How do you actually foster the culture in this regard, and ensure that everyone's on the same page over and above the things that you've mentioned?
So, our culture first approach is really just making sure everyone in the team understands what we're doing as a practice and why we're doing it. I'm a firm believer in making sure everyone has their voice heard. Everyone has their concerns heard. I sit down with the team one-on-one if we're introducing anything new, and I ask their opinion. I ask, what they think. I explain how it could help the patients. I explain what potentially it would look like if we did have this new technology or a new way of doing things, and how it would impact on them, and see what they think, and see if, the benefit of introducing it into the practice, is for them in their eyes, worth it for potentially the extra work that they might have to do. And we as a practice prescribe to a growth mindset. We are continually looking at improving our services, and we actually like it when there's something that goes wrong, not because we like things going wrong, but because when we see that something hasn't been done right, or there's been a challenge or a setback, we just think about how we could do it differently for next time. So I think if we create a safe environment where people can speak up when there's something that's going wrong, you're going to be able to address anything early, as opposed to wait until something kind of blows up out of proportion. It's much better to address it straight away. And I hope to think that we have an environment where people feel comfortable just to, say what they need to say, and then we can just move forward with that.
Yeah, I know you've got a lot to say on that particular regard with culture and how teams work. And I'd love to ask more questions, but I'm going to stick to the task here and stay on the dry eye topic. But as it rolls out, and obviously we've spoken about a whole heap of mechanisms there that can be incorporated into practice. But let's say we're sitting with a practice, or a practice is listening to this, and they're like, I love it, but I can't do it. But now I know that I need to at least focus on this in some capacity. And if I can't, obviously perhaps refer and work on this referral system. Can you speak to that? And I think even through dry eye impact, and I do want to ask you more about dry eye impact, and I will after this, but with regards to this referral, concept, how would you go about doing something like that? And who are you looking for and how are you looking for things? And, if you're speaking about practice that, like I said, doesn't necessarily think that they're going to do it, but know that they should look for it and now want to sort of refer on, what are some of the key things to keep in mind in that instance?
I think, you do what you can with what you have, with the tools that you have, you try. And if the patient's not responding, it's frustrating for the patient and it'll be frustrating for you because, you're doing your best. I think that's probably when you should have the conversation that there are other options out there that could potentially help this patient. And you just put it into their court and you can say, I'm happy to refer you on if this is something that you'd like to have addressed. But I think it's always good to give the patient that option, especially if they have the persistent symptoms, because you don't want them to think that there's nothing that can be done for them, because then they're just going to potentially not ever look for a solution until it gets really bad. And then by the time they get to see someone, it's a lot harder to manage and to treat. So that's probably the good time when you've done everything you can and the patient's still struggling. It's very important to kind of give them that next step if they want to take it.
Yeah. And I think, it sort of kind of goes into a little bit of an interesting space here because, when you have to refer or if you are going to refer and it's to another optom, and it's only natural that one will think, well, how do you balance, I guess, that concern that another optom might have? And I mean, is that, being the optom, say, that would be referring and then the one that's been referred to, if you're being referred to, I guess you've got to give confidence to the other practice that, they're not giving away their patient. And do you have, I guess, any advice in and around that to ensure that you construct a well-designed referral program that ensures that someone that's not prepared to do it has the comfort to do it, and then the patient obviously is the beneficiary of all of that?
Yeah, so like when you do refer a patient, if you've referred them, we would just do like whatever it is that's bothering the patient. So like address their dry eyes and then send a referral report back. And I think that works quite well because patients, if they've seen an optometrist for a long time, they trust them, they're happy to see them, they're happy to get what they've, always gotten. And we've had a lot of patients who, when they come to see us, they know they're just coming to see us for dry eye and they're very happy, or more, if anything, they kind of only think of us as treating them for dry eye. And then they go back to their optom and it's interesting, they kind of see us and then I'll go, oh, have you had your, macular and all those checked? And they're like, yeah, I just saw, my optometrist the other day. And I go, good. So I'm like, I don't need to worry about that. And then I just focus on the anterior health. So I think that works quite well, but I guess I can see how that can feel uncomfortable. But really, I would say that if you don't tell your patient that there are options out there and they find out on their own that there was something that could be done, it damaged the trust that you guys would have with each other anyway. So I think, you let them know, whether it bothers them enough to do something, that's completely up to them. But it's not good, I think, to withhold that information because they might find someone that tells them about it, or they might figure it out, with the ChatGPT search that there are options out there, and they will feel a little bit upset if you didn't kind of explain it to them.
Mm-hmm. And I guess in reflection too, where do most practices go wrong when they try to build a dry eye service? Do they overcomplicate it, or do they underinvest in culture? Do they skip the basics, or something else? Where do you see that happen more often than not?
I think sometimes optometrists, talk about dry eye and they get into the nitty gritty and the technical when they're telling or explaining this to their patients. And there would be a massive information overload. I know it was something that we struggled with when we first introduced dry eye treatment to the practice. I think our patients would have had like massive overload as well. What we've learned is you really have to communicate the most essential points to the patient that's relevant to them. Otherwise, they'll be very confused. And a confused patient they don't know what to do with your recommendation. They're not going to know what to do with the next step, and it's going to be in the too hard basket. So just we've got to make that communication simple, key points very simple. And I think probably the most difficult thing to get dry eyes successful in practice is culture. That's a huge one. You need everyone on board. If everyone is on board, it makes everything so much easier. When the patient comes in, the way that people are talking about dry eye, the way that they might notice, oh, that sounds like you might need to see Shaina about this, and I think you'd probably be best to book in for a dry eye assessment. Those conversations happen all around you, and in the optom room, you won't hear them, but those are the conversations that make patients, when they walk in, go, oh yeah, they know what they're talking about, because the team knows what they're saying, because they've said it and they believe in it and they support it. Yeah, the hardest part of getting, dry eye successful in the practice, I think, is the culture, like getting everyone on board. We're lucky, really fortunate to have an amazing team who really do want to put our patients first. So I'm really lucky to have them. But once the team understand what you're doing and how you're helping patients, and when they start to believe in your vision of what you're trying to achieve, then it just makes it so much easier, because everyone, if anyone has a question, like everyone knows how to help this patient because they've gone through it, they understand it, they've seen it happen, and they just get better and better at it.
I mean, and you're so passionate about this category that you've created something called Dry Eye Impact, and we've referenced it a few times in our conversation already. But why did you create Dry Eye Impact, and what is the gap in the profession that prompted you to build it? And I guess, what does it look like? And can you explain to us that service and how it helps?
So I built Dry Eye Impact because there's such a huge need out there for optometrists to treat dry eye and treat it well so patients get good outcomes. There are so many people out there with dry eyes who are not getting the relief that they need with traditional dry eye treatments like eye drops, hot compresses or whatever that's available at that basic level. There's so many people that's just not working for them. And we have so many new technologies and solutions to help people, yet we're still kind of not maybe in that phase within like confidence in practice, or not sure how to bring that advanced technology into practice. But there's just such an opportunity for us to do better in the dry eye space. And that's why Dry Eye Impact was made, because it's made for people who potentially want to start, don't know where to start, worried to start, and it'd just be good to have someone who's done it before walk you through the journey, get your practice to where it needs to be, and start helping these people that really do need help out there in the community.
And I guess from that point of view, if anyone's listening, and obviously we've gone through a heap of tips and points that will help someone get started, but obviously Dry Eye Impacts helps in that regard. So definitely be encouraging to reach out to Shaina and to the team at Dry Eye Impact to see how they can assist, because it seems to be a given. I mean, if you're looking for advice and support and some guidance, it would be a great place to start, I imagine. You've also presented internationally on the topic in Japan, I believe, quite recently, if I'm not mistaken. What does Australia do well? And you've just mentioned you've come back from the US. What does Australia do well when it comes to dry eye? And I guess, where are the areas of improvement that you see dry eye going? And I guess, what's the future of it?
So I feel we do pretty good in Australia in the sense that we do have a much broader scope. We have access to these advanced technologies. We can prescribe the specific drops that we need to. Japan's a bit different to Australia. Dry eye care is primarily ophthalmology led. So it's very, regulated and there's not very many, accessibility to dry eye care, because there's not as many ophthalmologists as there are optometrists in Australia. Mm-hmm. So I think Australia has a really huge opportunity. We have the training as optometrists. We have the technology available. It's just a matter of now, utilizing the technology, getting the outcomes for the patient, because we've got so many optometrists scattered across Australia to be able to address this problem well. Places like Japan, they've got much less resources in the sense that only the ophthalmologist can treat dry eye, and there aren't as many of them. So even if they had all these people coming to see them for dry eye, they wouldn't be able to do anything else. We've got a really unique situation in Australia where we really, all of us, can be addressing this issue, and it's all within our scope of practice.
Yeah, it's such a massive, I guess, opportunity when you put it like that. And as we start to age as a population, which we are as well, and whether it's an age-related thing, and actually that's a good question. Is it age-related? Is there any symmetry between the age of a person and dry eye, or can it affect anyone at any age?
It definitely affects people as they get older. Over 50s, you're much more likely, 1 in 3 Australians have dry eye if they're over 50. It affects women more because we go through those perimenopausal hormonal changes. In saying that, we are seeing an increase in dry eye patients that are much younger, people who do a lot of screen-based digital device kind of work as part of their work. That reduces their blink rate, which reduces the amount of time that they have tears over their eyes because they're not blinking as often as they should.
And I guess as I'm really thankful for all the insights and all the tips that you've shared today. It's such a massive area, and I think there's so much room for growth. So all those insights that you've been sharing are really appreciated. And as we sort of conclude, if someone's looking at getting into dry eye, I mean, obviously we've gone through it quite a bit today, but what would be the first thing? What would be the next step? What would be your words to somebody that's sort of, contemplating doing this?
I guess I would encourage them to do it. I really think if that's something you're interested in and something that you want to move forward with, I'd like to be the voice of encouragement, because I know what the voice of discouragement is like, and that wouldn't make you feel like you'd want to go ahead and do it. I'd like to be encouraging because dry eye right at this moment it's really exciting. There's a lot more investment. There's a lot more people and research looking into this space, trying to basically bring solutions to patients, because this is such a big problem and it will continue to be a big problem. So if it's something you're interested in, I'd say go for it, get some experience under your belt. And then if you're ready to move on to the next step, just ask, join the Dry Eye Society, get around like-minded practitioners who've done it already, so you can just speed up your progress and really get into it.
Yeah, and I love the fact that you said that you want to be that sort of that voice of encouragement, because it's rare to find individuals like that, and I feel like if there's anyone listening, they should definitely take you up on that offer and listen to your words of encouragement. And on that note, if anyone does want to get in touch, what's the best way for people to find you?
So I'm really happy to connect and work with optometrists who want to bring dry eye into their practice, or if they've already got dry eye advanced technologies in their practice, help them grow their practice and utilize what they already have. If you would like to learn more, you can visit the Dry Eye Impact website, which is www.dryeyeimpact.com.au. And I'm pretty active on LinkedIn, so you're more than welcome to message me there.
And we'll make those comments available and those links available in the show notes. So if anyone wants to reach out to Shaina, you can jump on there and get those details as well. Shaina, I also know that you're in the processes of writing a book and at the very end of it, and it's all to do on the topic that we're speaking about today. So can you talk to us about your book and give us a bit of an insight as to what it's about and I guess when it's going to be available?
I'm so excited to talk to you about my book. It's called The Dry Eye Imperative, and it's a clinician's perspective, so my perspective, on the patients that we overlook and the care that we miss and what needs to change in optometry for dry eye. The book is really for optometrists, especially optometrists who are passionate about improving dry eye care, or optometrists who want to communicate more confidently with their patients about dry eye. And it's also for optometrists who'd like a really practical, because I'm really a practical person, a patient-centered as well approach, rather than like a textbook. It's very conversational. And it's for optometrists who believe dry eye does deserve a greater place in everyday optometry. And what you'll get from the book, I hope all optometrists who read the book feel more confident after reading the book, have better patient conversations, gain and learn a practical framework on how they can, talk about dry eye and be successful, and get real world insights, and then potentially have a renewed appreciation of dry eye care. Because dry eye, for me, it's one of the best patients to help. And when you are able to help them and you see them go from, uncomfortable, upset, uncomfortable eyes to, happy, really happy to have their eyes back again or have their life back again, it is really a privilege to be able to help these patients. And if you can help one or two or many of these type of patients, I know it will be such a rewarding feeling as an optometrist to have.
Yeah. Well, that sounds fantastic. And just the effort and energy to put together something like that, it must have been intense. What inspired that? Like, at what point did you decide you wanted to write a book about this? I mean, that's sort of taking it to the next level, which is awesome. But, what was the inspiration behind it? And I guess, how did it come about?
I guess I really wanted to write something and put my, stamp on it, in the sense that I'm not a very super highly clinical person. I'm very much a people and feelings person. And I think dry eye really requires someone like that, because it is such an emotional disease that patients have. So I just wanted to give my spin, because I know a lot of optometrists are clinical, are very task oriented, and I just wanted to put that people oriented spin into dry eye so that they can gain another perspective whilst they manage the condition.
Yeah, well, I love it. Congratulations. When is it out, and when can people expect to see it, and how can they get it?
So it will be out in September. I am still going through the rows of publication, but September is the date that I'll have the physical copy in my hand, and I'm really excited about that. You can get the book on pre-sale on my website at Dry Eye Impact, so you're more than welcome to. Yeah, I'm super excited.
Yeah, cool. No, awesome. And we'll put details of that obviously in the show notes as well. So along with how people can contact you, we'll share that, and really excited for that, and all the best with the book as well. It sounds like a really awesome initiative, and I think much needed as well. So congrats on that. But Shaina, thank you so much for your time today. I really appreciated learning more about dry eye, and I'm also, really inspired by how passionate you are about it. So you're doing fantastic work in the space, and I wish you all the best. And we'll chat soon. Take care.
Thanks, Michael.
Thanks for listening to The Focused View. If you've enjoyed today's episode, please leave a 5-star review, subscribe on your preferred podcast app, and share it with your colleagues. It helps us reach more eye care professionals across Australia. For additional resources and downloads, visit thefocusedview.com.au. I'm Michael Nasser. Until next time, keep focused. Thanks for listening to The Focused View. If you've enjoyed today's episode, please leave a 5-star review, subscribe on your preferred podcast app, and share it with your colleagues. It helps us reach more eye care professionals across Australia. For additional resources and downloads, visit thefocusedview.com.au. I'm Michael Nasser. Until next time, keep focused.